has moved to his second worksheet, which there is a second worksheet in your folder. I apologize for not telling you about it earlier. I thought maybe I was lucky you all noticed that there's a second worksheet, so you might reflect on what you heard. There are 3 questions there on the top related to the Medicaid providers or Medicaid office presentations about their key messages from the different state plans, which clearly was related to the home health, or health home. Why can't we add a Y to that? Health E-home. Anyway. And then how does your program fit within your own state? How does it fit into that comprehensive asthma care model? And boy, I can immediately see how our program fits, how many of the programs that are represented here today fit within both of those models that could immediately work in both states to expand services and help develop services. And then what resources do you need, your organization need, to implement those additional services that were described so that you can help implement these services and assist in providing comprehensive care. So think about those while you listen to our panel, but you're also going to have to write about them as well on the back side there. So this afternoon's panel will be talking about programs with a little bit of focus in Missouri because of the more formal asthma organization structure across the state. There's been lots of activity with a Missouri Asthma Coalition, with some statewide initiatives and programs, a state asthma coordinator, some CDC funding, so that some of that infrastructure is clearly in place and has been working for some time. So we're going to hear from some of those programs and some best practices that certainly could be translated, and some of that process is beginning to happen to translate to Kansas. So we'll start with our first speaker, Dr. Ben Francisco. He's an assistant professor of pulmonary medicine and allergy in the Department of Child Health at School of Medicine, University of Missouri-Columbia. He's the director of Asthma Ready Communities and principal investigator of several asthma improvement initiatives. He's a practicing pediatric nurse practitioner at MU Women's and Children's Hospital, University Physicians Pediatric Specialty Clinics, Columbia. Whoa, do you have to say that every time you're yeah. Dr. Francisco is the principal author of Impact Asthma Kids, an evidence-based multimedia education program for school-age children, and his research activities include analysis of administrative claims data to target and evaluate asthma interventions, workforce development to improve asthma care at schools, clinics, hospitals, and community agencies, assessment of airflow obstruction in childhood asthma, and improvement of children's inhalation technique. So please welcome Dr. Francisco.
Thank you very much, Kevin, and thank you, everyone, for being here. It's been rich, and I've learned a lot. I want to focus just a little bit for 10 minutes, a quick overview of where our work, which is converging after about 10 years of collaborative work here in the state of Missouri with focusing on workforce development. Our current interest really is looking at how do we help people make better decisions. And one of the great things about our national guidelines is they focus on a partnership. And this has been in place for 20 years, the concept that we need to partner with patients, that decision-making should be a joint process. And we think that there's a great opportunity to help to take data to drive that process. And it's claims data, and it's really focused asthma assessments. I think we need to really belly up and say that we don't do a very good job with assessments in the asthma world. If you have diabetes, you should know your blood sugar, your A1Cs, but we still have thousands of people with asthma who've had no objective measures of airflow, and they have no earthly idea whether they're breathing well today or not. And we need to find out whether they're at school or in the clinic or at home with a visitor to help them reduce triggers. So good assessment data coming from a variety of sources merged with claims data will open our eyes. And what we see is sometimes scary, how sick people are and how their resource utilization shows that they're really in a lot of trouble. And we should step in much, much earlier and not wait until they're in trouble. So really this is what I think an efficient healthcare system would be doing. We would be merging what are essentially clinical measures, assessments like FEV1, level of impairment, as well as in-home assessments, are there known triggers or things contributing, with claims data, which tell us things that clinicians just don't know. Our clinical histories are woefully inadequate to answer the question, have you consumed enough inhaled corticosteroids to expect control of inflammation? And there's great discordance between what people tell us and what claims data show us. So thank you to MoHealthNet for making administrative claims available online. I use them every day as a clinician, and I've stopped crying and I'm facing the music that patients either don't know or don't accurately report what they really do with medications. So we've got to be smarter on this front, and the good news is there's a lot of real simple logic that can take us a long way towards better care and better outcomes. These same data tell us who needs special services. Not everyone needs in-home trigger reduction, but those who do, we want to deliver it quickly as we can do it in a cost-effective way. So this is an important step. The other thing that frustrates me is that we talk about education as if it were one thing, and it clearly is not one thing any more than medications are a single asthma medicine. We have a complement of treatment approaches. So I think everyone needs asthma literacy. Everybody has a right to understand what asthma is and what the critical medications are and why breathing your medicine in a special way is important. But when you look at these sort of 8 interventions that we should be delivering in a smart way to the folks who need that level of care, you'll see certainly home trigger reduction as a critical step. And if we target it correctly, it's definitely going to be cost effective. But I think we need to be smart about deciding who likely would benefit. And sort of the logic behind this becomes clear when we look at the indicators that our expert guidelines tell us matter. And that would include ICS adherence, level of airflow obstruction, level of impairment, management of comorbidities. And when you get those things right and you have a sick patient, you can almost be certain there's something in the house keeping them ill. But before you get them taking their ICS, before they learn to get the medicine into their lungs with good inhalation technique, we might not want to rush to more costly interventions. So what I'm concerned about is that we put in front of clinicians those questions. When do we need to think about the environment? And of course, we start in the very first visit, but when do we progress to say we need help, we need a team to go into the home? And how do we move the family, the individual, towards asking those same questions? Is my house making me sick? So at the very first encounter, we have to raise that awareness and pursue it throughout. So the other thing that we have a wonderful opportunity to do is to align our practices with the evidence. We have great guidelines. EPR3 provides us with working tools to provide care in all settings. It simply isn't happening. And the more we travel, we've trained 138 clinical teams across the state of Missouri. And I say clinical teams. Those are physicians, nurse practitioners, medical assistants, registered nurses, care managers, teams. That's how we deliver care. It's the way we've always delivered care, as teams. But as we get these teams in alignment with expert guidelines, they begin to see the problems. And they begin to also appreciate, on the clinical side, they can't do it all. We need community partners. We need a sharp school nurse that picks up on a kid who stopped taking their inhaled corticosteroid and who was in trouble before they hit the emergency room. We need folks who can uncover these serious problems in the home that will keep someone sick even when we spend a whole lot of money trying to help them. So the way we try to sort of model this or think about it is that we're wrapping around patients and families, always putting foremost their capacity to take care of themselves, to self-recognize, to self-modify, but also understanding that if we aren't practicing by the evidence, our care is substandard. If we don't measure airflow on the clinic side, in the school and other settings where we have health professionals, we're not assessing and monitoring the disease, which is a first step in good asthma care. We also are going to have standardized ways of intervening on the community side. And I appreciate the work that we heard about this morning with randomized controlled trials that really looked at, if we do this particular intervention, what can we expect? So in the asthma world, we need to be a little more sophisticated in saying, This is exactly what I mean when I say school-based asthma literacy education. We've now done it 1,000 times, and those children who have received that service experienced an increase in FEV1 of 15%, a marked reduction in impairment using the American Academy of Pediatrics scale, which is validated. So it's that precision that's going to help us move to the next point that will bring insurers to the table, I think, to pay the bills. And you know, one of the frustrations of training, and I've done this a lot now for the last 2 decades, I love it, I believe in it, I like to see people's face light up when they get it, but you have to have systems in place to help them implement what they've learned. And that's where our electronic health records and our information exchanges are woefully inadequate, because we have good people who know the basics, but they need systems in place to help them do the right thing every day. So expert guidelines tell physicians how to step up, nurse practitioners and others, how to step up or step down care. And we talk about cost today. 3/4 of asthma care costs roughly are pharmaceutical costs. And if we don't do this right, we're going to break the bank, and we're not doing it right. We have drug utilization reviews now for the state of Missouri, just refreshed about 45 days ago, and the data tell us we are not prescribing by expert guidelines. We can fix that. We need some prompts and some reminders, but we can fix that. And we should. We must fix it if we're going to make progress. But here is where, in expert guidelines, there's clear guidance to the clinician. Consider the environment. It says, if a patient is not well controlled, first check adherence, and that should be claims data. Then check inhaler technique, because you can consume an inhaler but swallow the medicine and get no benefit. And then check environmental control. So we have clear guidance that says, think of the environment, go to the environment after you've taken care of these 2 basic things. And at the bottom here, I want to just click, and if the internet connects, and we'll be able to load things up. I'm saying today that if I'm a clinician and I don't see claims data, I'm going to be blind to some very important things. I need the claims data. So here's a little application we've developed called the Asthma Control Monitor, and it has all the critical EPR3 indicators embedded, but it also says, provides other key data like antibiotic use, how many antibiotics have been prescribed, fidelity, how many different prescribers are writing scripts for this patient's asthma medicines, inhalation technique, does this patient know how to breathe in their medicine? So what I'm saying is that if I'm an asthma-trained provider and you give me a powerful tool, I'm going to populate it for a patient. And this is bringing assessment data and claims data together, and it says this person's using more than 7 doses of albuterol a week. They've been on more than 3 oral steroid bursts. They've had more than 6 days in the ER or the hospital. And they haven't had a flu vaccine in 2 years. Their inhalation technique's poor. Their cost is way out of alignment. And down here, lo and behold, we have an environmental risk score, and that's derived from Kevin Kennedy's Healthy Home Score, and this patient's family filled out a 10-point item, and it said they're in the at-risk category, a score of between 50 and 65. So as a clinician, I know kind of where I need to go. If I'm a care manager, I need to know where I need to go. And if Kevin has capacity to serve my panel of patients, I'm going to pull people that are in the red zone or the yellow zone and say, let's start here. So better tools, better results, and I'm going to stop there.
Thank you, excellent. On to the next speaker. So, Dr. Tim Johnson is the Medical Director of Children's Mercy's Pediatric Care Network. Prior to joining Pediatric Care Network, Dr. Johnson was Associate Chief Medical Information Officer here at Children's Mercy. Dr. Johnson is a practicing pediatric emergency medicine physician, and he's been with the hospital since 2000 when he began his residency in internal medicine and pediatrics. So please welcome me.
Right in the middle of the lunch lull right now, I imagine. So hopefully keep this a little bit interesting. I don't have slides, but I want to talk a little bit about the Pediatric Care Network at Children's Mercy and what we're all about. and then I'm going to tell you why that might be important.
All right, hopefully you can hear me anyway, because I do tend to talk loud, so if I'm yelling in the mic, please let me know. So the Children's Mercy Pediatric Network was started for two reasons. The first reason, Children's Mercy used to own an MCO. It was called Family Health Partners. Many of you know it. It was around for a long time. We did relatively well as far as providing care, and we didn't lose money. We make much, but we didn't lose money. And we decided, the hospital decided about 2 years ago, that it might be time to get out of that business. And we did that because of the potential for a bunch of adults coming into Medicaid. And we thought, you know what, we're a pediatric organization, we're really not very good at taking care of adults, we really don't want to do that. So we decided to get out of that business. But that was only one of the reasons. The other reason, which this is going to be a reoccurring theme and what I'm going to talk about, change is coming. And the change that is coming is fee-for-service is dying. So we've talked a little bit, some of the presenters have talked about capitation and those types of things. Now, you can prognosticate a lot about what it's going to look like in the future, but the one thing I think everybody in this room can be sure of is it's not going to look like what it does now, because we're spending 18-point-something% of our GDP on healthcare, and we cannot do this anymore as a country. Doesn't matter what your political persuasion is, that's a given. We can't do this anymore. Something's going to change. So the hospital decided, well, we don't know what that is, but we're going to try this and see what happens. So we went back. We sold our company to another insurance company, and then we went back to them and we said, well, you guys are going to take on a bunch of adult business here pretty soon, probably. Why don't you let us take the pediatric business off your hands? You give us a fixed set of money, take your profit off the top, and we will manage that. Everything that happens to them as a provider organization. So we're the providers. We're all the providers in the hospital. We are a network of community providers, which is somewhere over 40 practices now. And we will be responsible. Whatever happens, if the patient goes to the ER, we pay for it. If they go to the hospital, we pay for it. If they go somewhere else, we pay for it. Now, that's a lot about money and not much about the patient. The key is, it's all about the patient. Whatever happens to that patient, we as a provider organization are responsible. So why that's important to this discussion is, a lot of the things that you were talking about, you would say, well, gee, if you just did X, then you'd pay less for Y, and the patient would be better off. Yes, exactly. And that's exactly why we did this. Now let me talk a little bit about what's different. One of the things that's different is we're a provider organization. So we're made up of providers. Now, we used to have a disease management program, particularly for asthma. Some of you may be familiar with it. We don't do that as much anymore because now we do something better. So it used to be we had a traditional insurance disease management program for asthma, meaning that there would be a case manager. If you were a patient that had a lot of hospitalizations or high utilization or high payout, somebody would contact you and say, well, we're going to work with you, patient. You have asthma, and we're going to ask you to do these things, and we're going to teach you about your asthma. And we sort of kind of worked with the providers, but not exactly. I mean, we used the providers as a vehicle to get to the patients, but we really weren't part of the care team. We're kind of, that's the problem with insurance. You're not really part of the care team. You're outside the care team. And now we're not. So now we are all about primary care. The foundation of what we do at the Pediatric Care Network is primary care. We make primary care work. So we go into primary care offices and we teach them how to be a medical home, a patient-centered medical home, meaning that the provider, the patient-centered medical home, is responsible for working with the patient and figuring out how to deliver care in the best way for that patient. It means we do population management, and we do planned care, and we do standardized care. And all of those things create a better outcome. And most importantly, we make the providers responsible for the outcome as well as the patients. So our providers get more money if they have good outcomes. And if they don't, they get less, which is a big difference from fee-for-service. Fee-for-service, you see more patients, you get more money, whether they do better or not. So that's kind of the difference as to where we are. Now let me talk about asthma a little bit. We talked about this disease management program that we used to have. So what we do now is we go into a provider's office and we say, we're going to give you a registry. More importantly, we're going to teach you how to make a registry with the data that we share with you, which includes claims data, which you were just talking about. And then we teach them how to combine that with their, unfortunately a lot of them don't have EHRs, but with the data that they do have. And then we make a list. And we teach them to say, well, you have 50 patients with asthma. Did you know that in the last 12 months, 20 of them have never seen you? And 10 of them were in the ED last month. And 3 of them are in the PICU. Did you know? And most of the time they say no. Because they have no way to know. How would they know? The patients don't come back to them. They may come here and never come back. They may just not go. So what we do is we try to make primary care work, and we try to give primary care the tools to do that. And then while we're doing that, we still do a lot of the education, a lot of the things that you were talking about. We try to teach the primary care providers things that they might not know about how to do step-up therapy and step-down therapy, and how to talk to their patients about motivational things. We have a person that helps with motivational interviewing. We go out and talk to practices about how to talk to patients to get them to do the things that they really should be doing, which I'm learning does not come to physicians very well. You would think that it would, but it doesn't. Just me telling you to do something doesn't mean you're going to do it. We have to figure out how to understand each patient's situation, how to put yourself in their shoes, and that's a science all itself. So we try to do that with our patients, with our providers as well, so then they can do it. So again, the reoccurring theme that we do is we drive everything back to primary care, because that's what has to work. Specialists and hospitals and all those things are great, and we provide great care here, but primary care is where it's at, and that's what we need to make work for this to work. So that's a little bit about what we do at the Pediatric Care Network, and I think I'll turn it over to the next one.
Our next speaker is Dr. Jay Portnoy. He's the Director of the Division of Allergy, Asthma, and Immunology at Children's Mercy Hospitals and Clinics. He's a Professor of Pediatrics for the University of Missouri School of Medicine, received his medical degree from the University of Missouri-Columbia, so long-time Missouri person, and did his pediatric residency right here at Children's Mercy. That would have been a long time ago. Just kidding, just kidding. He has published numerous articles in peer-reviewed journals involving asthma disease management, environmental control, and mold allergy. More recently, he's been involved in evidence-based medicine and is co-chair of the Joint Task Force on Practice Parameters. Dr. Portnoy served as president of the American College of Allergy, Asthma, and Immunology in 2008, and he currently serves on numerous committees, both for the American College and the American Academy of Allergy, Asthma, and Immunology, as well as on the Allergy and Immunology Residency Review Committee for the ACGME. So please welcome Dr. Portnoy.
Okay, I'd like to thank you all for inviting me today, and welcome to Children's Mercy Hospitals and Clinics. I'm one of the providers that we were talking about, and I didn't arrive until after lunch because I was in clinic this morning taking care of the kinds of patients that we've all been talking about, patients with asthma. And that's what I do for a living. I'm very fortunate because I get to work with folks like Kevin here, who runs the Environmental Health Program. I also get to work with folks like Candace and Tim Johnson and administrators at Children's Mercy Hospitals and Clinics who've allowed us to have an environmental health program. That's a very enlightened thing to do because children's hospitals don't have environmental health programs. So I'm very fortunate to be able to do that, and it's really great. Before I move on to what I'm hoping that you'll get, let me share with you the reason why I got interested in environment, and that's because I saw patients like someone that I saw last week. I'm going to call him James. It's not his real name because of confidentiality, but let me tell you a little bit about James. James was an 11-year-old with asthma, and his asthma was really severe. He had seen a number of doctors, and the fact is I was essentially a fifth opinion for James. His asthma was very poorly controlled. As with most asthmatics, he was coughing, wheezing, and having labored breathing on pretty much a daily basis. And in fact, he would wake up every night in fear that he wouldn't be able to breathe. He really was a very frightened young individual. Very scary type of thing. James was admitted to the hospital 6 times this last year. About every 6 weeks he was admitted to the hospital. James couldn't participate in sports. That's a really bad thing for somebody who's 11-year-old. A very, very problematic thing. It wasn't that James wasn't being adequately treated. When I asked the mother, well, what kind of treatment is James having, she pulled out a huge Ziploc bag from her satchel and stuck it on the table, and it was full of pretty much every medicine you can think of that somebody with asthma would take. So he was taking lots and lots of medicine, and I think he actually was taking it because James was having lots of side effects. He was a short person because he was on so many steroids, so he really was taking this medicine. It just wasn't working. We did objective measurements. His nitric oxide was 126, if you know anything about that. 25 or lower is normal. That's a very high number. It means there's tremendous amounts of inflammation in James's lungs. In addition, James had severe obstruction on his pulmonary function test. When I examined him, he was actively wheezing, inspiratory and expiratory wheezes. He had only fair air movement, which means that if he had been to the urgent care center, he probably would have been admitted to the hospital. The fact that he came to the allergy clinic, and we are used to that kind of thing, we just managed him. Gave him a steroid calendar with a tapering schedule, gave him instructions about how to do it, and talked to them about asthma. James, his real reason for coming to the allergy clinic last week was he wanted to go to camp. Think about a kid like this who can't sleep at night, he's sick every day, his lung function is really impaired. He wants to go to camp. This is a very scary thing to the mother. He's going to spend 5 days sleeping outdoors in a camp. Not too good. But he really wanted to do it. He wants to do sports, he wants to do camp. He wants to be a normal 11-year-old. You can't blame the kid. That's what anybody would want to do. We did allergy testing. That's what I do. I'm an allergist. Allergists do testing. He had significant amounts of specific IgE to rodents and to molds, a variety of different molds. My reflex also is to find out what things in the environment might be triggering the asthma. A normal person with asthma doesn't have as much trouble as James does. So what's different about James? It turns out that there's a history of a rodent infestation in the house. The family had seen lots of mice, so that could be a significant problem. And they really couldn't tell me about exposure to molds. The mother didn't know whether there was mold or not. What's the history of mold? What kind of thing would mold, what would that be like? I'm just trying to get my notes going here. Okay, so we make a number of assumptions about people with asthma, with other diseases as well. We assume that if you have a disease, chronic illness, that there's something intrinsically wrong with the patient. If you have heart disease, that it's because you have clogged arteries. If you have diabetes, you don't have enough insulin. Basically, there's something wrong inside of the patient. We don't assume that there's some environmental cause of that. And yet, if you think about it, with heart disease and diabetes, we actually do attribute an environmental cause to those diseases. It's diet and exercise. What you eat affects your heart. At least my cardiologist tells me to know. What you eat affects your diabetes. If we could lose weight, then your insulin would improve. We can make that equivalent to asthma. What you breathe affects your asthma. Basically, asthma is an externally triggered disease. It's not something wrong with you. It's not the smooth muscle disease that we learned about 20 years ago. It's an environmentally induced illness. And if we don't address the environment, the thing that's driving the asthma and making it sick, it's not going to get better. James was taking all of his medicines. He was getting sick from the medicines. It wasn't working. We needed to do something different. Okay. All right, so this requires a collaborative approach. When we started our environmental health program, we hired an environmental health specialist. I fortunately get to work with Kevin. We had somebody else 15 years ago here when we started this. We needed to figure out how to do a home assessment. We didn't know. Nobody really defined that. We've now done over 400 home visits, so we have a pretty good idea of how to go into a home and figure out what's going on in that home and identify the triggers. We also need to train the other home assessment people around the country how to do that. Kevin and his team have been actively training environmental health professionals using a Healthy Home Practitioner course. I've actually taken the course. If you get a chance to do that, it's an absolutely fantastic course. It's 2 days long and you learn a tremendous amount. So I really enjoyed doing that. The team has been traveling all over the country teaching environmental health specialists how to do it. There's even a certificate, Healthy Home Practitioner. They've developed level 2 training with the technology and the analytical work so that it is standardized. And they know how to write reports so that practitioners can receive the information about it. As a physician, my colleagues want to know which patients need to get a home assessment. As an allergist, when I identify somebody who's not well controlled and they have lots of problems, those are patients who may be candidates for a home assessment. But more important, we've developed prior authorization criteria. We're not talking about sending every patient with asthma to a home assessment. If you work in a health plan, you would not really want that to happen. But we can identify specific individuals who definitely would benefit from a home assessment and undergo prior authorization so that you can keep track of that and keep tabs on which patients there are and not break the bank by doing too many home assessments. In addition, my colleagues want to know how do we identify an expert to do the home assessment who's qualified, who's going to do a good job. That's where these credentials that we've come up with and are working with the credentialing groups are very helpful because we can show our colleagues how to identify an effective home assessment and how to interpret the results of the home assessment. So by doing all of those things, we have a collaborative effort that's very helpful. Okay, so we've taken a number of steps. As I said, we've gone into over 400 homes. We've identified the process for doing that, and now it's a thing that I can actually order. So what's left to do? The bottom line is I can order CAT scans, I can order blood tests, I can admit patients to the hospital, I can do lots and lots of things that are very expensive, and if you work at a health plan, you're paying for it. As a society, we're all paying for it. I can prescribe medicines. I can prescribe over $4,000 per month medicines to my patients with asthma. It's very, very expensive. But the one thing that I really need to have done that will help the patients not be sick and not need all of those things is to be able to write an order to have an environmental assessment done for my patient. That's the thing that I think is the most important. That's preventative, that improves health of the patient, and it reduces the need for all this other stuff that is often not very effective. That's what we need. That's what I'm asking you all to help with. We need to be able to reimburse for and order environmental assessments so that we can help our patients to do better. Otherwise, we're not going to make the progress that we need to have. We did have, as Tim Johnson mentioned, a disease management program with Family Health Partners. That was a disease management. I think it's more global now. It's much better because it doesn't deal with disease management. It's more patient management, and I think that's a better approach. But for the disease management program, when environmental health was a component of a comprehensive program, we were able to demonstrate a 60% decrease in emergency room visits, 50% decrease in hospitalizations. We were able to show improvements in quality of life both for the physician, for the patients, and satisfaction for the physicians and for the patients. And most important, we demonstrated a significant decrease in the cost of care for patients who had asthma. And I have no doubt that the Pediatric Care Network will experience those same good outcomes once the disease management components are integrated into the patient management components, which is a more global approach that I think is really, really helpful. Okay, what about James? I spoke to James's mom this morning. That's the reason why he came to mind as I was preparing these words. James's mother actually said that he's doing really well. His health has improved. He's actually on his way to camp this evening. It's a very scary thing for them, but they're doing that. This is the first time that he's actually been able to breathe without being afraid of waking up at night and not being able to breathe. So James is very excited about this. They've got a lot of hope. We prescribed a new procedure called dynamic dosing. Right before I came here, I gave a talk to our hospitalists at Mercy South on dynamic dosing at noon, right before I came here. It's a new procedure for treating asthma. It's one that you're probably going to hear about. It's different. It gives the patient more control over it, and it may replace asthma action plans in the future, but we'll have to wait and see. But the most important thing is we need to get James into an environment where he can breathe clean air. And that requires that we do a home assessment to figure out what the problem is, we identify interventions, and we get that taken care of. And so that's where we need your help. As partners, all of us together, we can help our patients to breathe better and to be healthier. So thank you so much, Kevin, and everyone for coming to this meeting today.
All right, our final panelist is Dennis Dunmeyer, graduated cum laude from Whitmer University School of Law in 2003 with a Juris Doctor degree, and from the University of Pennsylvania in Social Policy and Practice in 2005, and a master's degree in social work. Dennis is currently licensed as a clinical social worker in Missouri and Kansas, has been with the Kansas City Care Clinic for 4 years, where he is Vice President of Behavioral Health and Community Programs.
Thank you. I am a wanderer, but I've learned over the course of several presentations and a brief stint as an academic that actually isn't a good way for me to present, so I'm going to stand behind the podium. I'm conscious that we're, according to our agenda, out of time, so I'll try to be brief. So one of the questions that Kevin posed to us today was, what's the common theme, or what's one of the things that stands out to the most to us throughout kind of the course of the day? One of the things that's come back to me, and I know this is because of my own personal bias and some of the professional lens that I work in, but we keep coming back to this idea that we need to be able to get an environmental assessment done for these patients. We also have talked at length and looked at different models about the idea of care coordination and making sure that what we do is accountable across all of our providers. And we've heard from some of our colleagues in Washington and Oregon about a couple models that they have found that have worked really well. So I'm going to talk a little bit more about what's going on locally, not specifically in the area